Hello guys, a very good evening. Hope I'm audible and visible. So how was UNICET? I hope UNICET was good and you guys have given a decent one in UNICET exam. I hope there's nothing much problematic, at least from the pathology MCQs. Most of them were straightforward questions, right? So we didn't have much of troubles in pathology at least. I'm not sure about the other things. Hopefully they were also easy. Okay. So today we have dedicated some time for us to discuss about some USMLE questions. Few questions from UWorld and few questions from various textbooks for USMLE. So because I'm trying to take more questions on sessions on the MLE, because the proposed next or NEET exam, whatever it is, they are supposed to be having more long stem based questions. That's what at least we are thinking of. And most of the questions which came in the last NEET exam also had a similarity with UWorld, right? So understanding questions which comes in UWorld will help us to crack your NEET exams as well, your NSL exams also. And if possible, if you're writing for MLE, that might help you as well, fine. So these are two things I wanted to tell. There are, okay, there's something blurred here, it's fine, yeah, got it. So we have a topic-wise MCQ discussion in the Unacademy app, which will be from 8 to 9 p.m. daily. Okay, I have some errors in it, it's not working properly. Just give me some time. Okay, so 8 to 9 daily we'll have questions which will be discussed on the Unacademy app, fine. Okay, and this will be, all of them will be special classes and you can attend whenever you want it. And Monday, tomorrow, we'll be having CBS, then we'll be having lung, and then will be a GIT. And these are for aspirants who are attending the upcoming NEET and MLE exams or your NSL exams, right? And we also have a thing called Disease 360. This will be for your professional year, second, third or fourth professional year. If you want to, if it helps you to understand the concept completely. We did about bone non-neoplastic conditions a little bit, and we'll be doing with Monday with myositis dystrophies and MAN complications and necrosis cell death. And these will be going together along with few MCQs at the end of it, right? So we have from 8 to 10 almost every day except Sundays. Sundays we'll have some sessions on YouTube which will be dedicated for you. On all these will be special classes and you can attend them whenever you want, fine. So without any delay, we'll go to today's MCQs, and these are going to be from UWorld. I want you to read the MCQs, give it some time, maybe a couple of like 30-40 seconds, and then I'll comment on the answer, then we'll discuss the same questions, fine. I hope the questions are visible. Yeah, they are, so go ahead. I hope the font is good as well. What's the answer? Okay, I'll go ahead and read the question and then we'll comment on the answer. Anyone else? Okay, fine, we'll go and read the question first. A 4-year-old kid is brought to the clinic due to an inward deviation of the eye. Examination shows a pale red reflex in the right eye related to the left eye, fine. A dilated fundoscope shows a well-circumscribed white mass within the retina. So what is the probable clinical diagnosis here? I have a 4-year-old kid with a mass in the retina and a red reflex in the eye, right? So my probable clinical diagnosis here, at least the primary diagnosis, will be an retinoblastoma, right? Possibly a retinoblastoma. Let's go ahead. Germline analysis mutation analysis shows a germline mutation in the patient's cell leading to the development of the mass. So the patient is having a retinoblastoma and the question says there's an RB gene mutation which is causing the problem. Which of the following is the most likely function of the protein which will be affected here? The question is directly asking about the function of RB gene which will be affected in case of this patient, right? So I have 5 options here, and function of RB gene will be affected is option D, right? It will prevent my G1 to S cell cycle transition. When you take a retinoblastoma, I'm sure you must know about cell cycle. What are the phases of a cell cycle? We have G0, G1, S, G2 and M, right? Those are the phases of cell cycle. So what's going to happen in retinoblastomas, we have to understand about normal retinoblastoma, how they function, and that will be easy for us to go to the abnormality when it will cause a cancer, right? Retinoblastoma, if you know the normal function, we can also extrapolate whether it's a tumor suppressor gene or a proto-oncogene, because that might also come in an MCQ, fine. I hope the other thing is ready for me. So I'll keep shifting this so that it will be easy for us to understand, fine. So when you go to a retinoblastoma, as such, when you have a normal cell cycle, I'm sure you must have read about cell cycle. We have your G0. G0 is a resting phase. I have G1, I have S, I have G2, and I have M, right? This is a normal cell cycle. So normally most of the cell, the predominant time spent in a cell cycle is in the G0 phase, right? Once it enters the cell cycle, it will enter into G1 phase, right? So after it comes to G1, in a normal cell cycle, I have two checkpoints. One in the G1S, there will be checkpoint here, and there will be one more checkpoint in the G2M, right? These are the places where my cell cycle will stop for some time to check for some errors, okay? So after checking for the errors, if there is no errors, it will automatically go to the next one, fine? So in a patient with, for the G1S checkpoint, right? The G1S checkpoint, what we have here is, to cross this, we have your retinoblastoma gene here, right? Let's say that if the retinoblastoma gene is active, that's the normal function, it will be in a hypophosphorylated form. When I have them in hypophosphorylated form, they're going to stop the cell from G1 to S transition. That's the normal function, which means an RB gene will not let my cell to go from G1 to S. So it's going to stop cell proliferation, or it's going to promote cell division. It will stop cell division, right? So it is a tumor suppressor gene, right? Anything which is going to stop cell division will be a tumor suppressor gene, right? So if my RB gene is phosphorylated, right, it's going to be hyperphosphorylated with the help of your cyclin dependent kinases, okay? With the help of your cyclin dependent kinases, it will become hyperphosphorylated, and I'm going with the other one itself, okay? Once it becomes hyperphosphorylated, what's going to happen for me is, sorry for the inconvenience, the RB gene will become inactive. When the RB gene becomes inactive, it's going to allow a cell to move from G1 to S, right? So it's an inactive state, right? So in an active state, normal RB is going to stop the cell division. In an inactive state, it's going to promote cell division, right? So this is a tumor suppressor gene. So as the question says, prevention of a G1 to L cell cycle transition is the normal function of an RB gene. If it becomes inactive, or in case of the disease mentioned, I'll have an LOF, a loss of function mutation, which will result in your evasion of cell cycle checkpoint. Automatically every cell will move from G1 to S. Once every cell moves from G1 to S, I'm going to have a defect, right? I will have lots of cell proliferation, which will result in a tumor, okay? What is the other name of RB gene? I'm going to write few genes here. You're going to tell me the other fancy name of these genes. RB is also called as a governor of cell proliferation, right? We call them a governor of cell proliferation. And what do we call for an P53 or P63? P53, we call them a guardian angel of a genome, right? So it governs my cell proliferation. That's why we call it governor of cell proliferation, because it's going to determine who is going to transmit from my G1 to S. And P53 we'll see sometime later. It's called as a guardian angel of the genome. It's going to guard every mutation which happens in the genome. So we're going to call them a guardian angel of a genome, right? There are two other names for my, yeah, correct, Yashwant is correct, P53 and my retinoblastoma, fine? So we'll go to the next question. I want you guys to actively comment so that it will become at least useful for you guys, fine? So I'll wait for a few seconds, and if you have an answer, then we'll go and discuss the answers. I hope the font is visible. If not, I'll read down the question. Maybe it will help you. A 64-year-old man develops diarrhea, abdomen pain, nausea, vomiting, and anorexia 3 weeks after starting a radiation therapy for prostate cancer. Physical examination shows an abdomen tenderness. A sigmoidoscopy shows hyperemia, edema, erosion, and ulceration from the intestinal mucosa. The stool and serum chemistries are normal. A radiation enteritis is suspected. So this is my diagnosis here, which is most likely secondary to the radiation therapy given for prostate cancer. Which of the following is the mechanism responsible for the patient's intestinal changes? In other words, the question is asking which of the following is the cause of radiation enteritis or any radiation-induced cell damage or any radiation-induced side effects, right? That's the question based on. So we have few options. One is generation of reactive oxygen species, increased activity of ubiquitin proteasome system, inhibition of DNA polymerase, and inhibition of thymidylate synthesis, and prevention of my microtubule assembly, right? I have many options given here. Answers? Okay, there are two answers. SN went for A and Yashwant went for E, right? Okay, so fine. Now let's go ahead. Radiation. What will radiation do to any gene? Anything. Radiation will cause cell death, right? Radiation will definitely cause cell death. So when I have radiation, it will cause a mutation, it will cause cell death. Anywhere in my body, cell death is primarily mediated by, this is necrosis or apoptosis, this type of cell death. It is inflammation induced cell death, right? So this radiation is going to cause an inflammation induced cell death. Once it causes an inflammation induced cell death, I'm having ulceration, erosion, edema and hyperemia. This causes necrosis. Whatever is it, the end point of anything in the necrosis is going to be my the end point of every necrosis is based on my reactive oxygen species radiated cell damage, right? Same thing, if you remember my reactive oxygen species, the formation of reactive oxygen species. Do you remember that UV rays is one of the important factors to create ROS, the free radicals? Yes, UV rays is the radiation. The same way, any therapeutic radiation I'm going to give will increase my reactive oxygen species, which will cause the cell death, right? So it's due to generation of a reactive oxygen species mediated cell death, right? So we'll have a look at the other options, okay? So when you have an increased activity of ubiquitin proteasome pathway, which disease which pathway do you think it is involved? Ubiquitin proteasome is very important for one of them. I'll erase them. Where do you think ubiquitin proteasome is involved? Or in other words, which of the cellular adaptation and ubiquitin proteasome pathway is involved? One is to destroy any protein, that's where it is involved. Ubiquitin proteasome pathway is also involved in atrophy, right? One of the methods of atrophy, the cellular adaptation, is either by apoptosis or an autophagy. In autophagy, there would be ubiquitin tag. Once the ubiquitin tag, the protein will be destroyed by lysosome, which leaves the residual pigment. What's a pigment? So anything which is older, okay, any older thing, an older protein or older cell will be ubiquitin tagged. Once an ubiquitin tag, they gets destroyed by a proteasome, which will be destroyed by lysosome, which results kind of in an autophagy mechanism, right? So this leaves behind a pigment. We call the pigment lipofuscin. So we call lipofuscin also as an wear and tear pigment or a pigment of cell injury, right? So ubiquitin proteasome pathway is a main mechanism involved in your atrophy. It's not going to be involved in necrosis. Radiation will not cause it, fine? Inhibition of DNA polymerase, there are few drugs, chemotherapy drugs which can act via that, or a bacteria or virus which can act via that. Radiation is not going to inhibit any enzyme. It will cause direct damage via inflammation, fine? And inhibition of thymidylase synthase, no, this is also not radiation. Prevention of microtubule assembly, again not radiation. There are chemotherapy drugs which can act via them, not a radiation, right? I think you might help me here. You must have read about pharmacology chemotherapeutic drugs. There are drugs which can stop your microtubule assembly. I think etoposide or topotecan, irinotecan, one of those drugs. I'm sure you know that, right? So these are methods which various chemotherapy drugs can act. Radiation will not act like that. Radiation acts via destruction via free radical damage, and the side effect also is similar, fine? Go to the next question. Again, this is a very simple one. I'll give it 30 seconds. Read the question, come to an answer. Don't be in a hurry. You might miss it if you're in a hurry, fine? Thank you, Santhan. It's called Jason. Okay, so let's go ahead and read the question. So we have one option, one of them we answered. Okay, one has gone for F, one has gone for E. Okay, a research scientist injects an hepatocellular carcinoma cell into the liver parenchyma of an experimental guinea pig. Serial observations show that the tumor cells progressively proliferate and invade the liver parenchyma to form a large mass. After some time, the malignant cells begin to penetrate the vascular basement membrane and gain access to circulation. During the process of basement membrane invasion, which of the expression of the following substance is most likely to be increased in the tumor cell, right? The question is very, very specific. It's asking during the steps of metastasis, which of the following will be elevated. If you have thought of option D, right? Because option D is when we always read, but that's increased or reduced. It'll be lost, right? When I have a loss of E cadherin, yes, that can give a result in a cancer, but not an elevation in E cadherin, fine? So E cadherin is one of the steps involved in metastasis, but what more important for me is metalloproteinase. Okay, we'll look at the entire perspective of cancer from a different point of view, because the metastasis is very, very simple and very logical. a tumor cell knows everything how my body reacts, and that's what it's going to do when it's going to invade and when it's going to cause metastasis. Fine. Okay, hopefully we'll have enough space here. Maybe I'll erase this part and they'll go ahead with it. So let's assume we'll take an example of an squamous cell carcinoma. That's the easiest one for us. Fine. And let's see how it will spread. Okay. When I have a squamous, let's say there's an epithelium here. I have tumor here, the squamous cells, pleomorphism, high insertion, everything, and it's going to damage the basement membrane and it's going to come below. Fine. So I'm right in saying that whenever I say invasion, it is nothing but it has gone below the basement membrane and it has reached my dermis, right? So this is my epidermis. I write E for a reference, and this part is my dermis, D for a reference. So here I'm having loss of E cadherin as the first step. So once an E cadherin is lost, a cell from the group will separate and become a single cell, right? This will become a single cell, and this will slowly move. It will slowly move, let's say to my blood vessel or my lymphatics. It's going to move. This is what happens. Fine. Now let's look how they actually act. So I'm having a single cell, an epithelial cell in the dermis. Dermis is made of collagen, right? So I'm right in saying that an epithelial cell is abnormal in dermis. Definitely it is abnormal in dermis. It's not normal in dermis, right? So when I have an abnormal cell in the dermis, I'm having a cell from the epithelium penetrating and coming into my dermis. Am I right in saying that this cell has caused cell injury, has caused tissue injury? In other words, yes, they have caused, right? So whenever a cell separates and comes to my dermis, it has caused a tissue damage. It will cause a tissue damage. Whenever I have a tissue damage, I may also right in saying that the next response to anywhere in tissue damage for me is a healing process. Yes, a normal wound healing. So I've destroyed a little bit of dermis. My wound healing will definitely start. In the process of wound healing, over the period of time, what do you think will happen? After a scar formation, the scar should get remodeled. Yes. So remodeling happens with the help of collagenase matrix metalloproteinases. That's what it does. So it's a cell here. I'm saying this dermis, it's going to invade here, cause a tissue injury. It will heal. It will wait for some time. It will then damage the same collagen. Then my cell will move. So again, when it moves here, more inflammation, more tissue damage, more destruction, scar formation, waits for some time, will remodel. While remodeling, it will move a little bit more. Again, destruction. So once it keeps moving here, let's assume it has reached a lymphatics or a blood vessel. A lymphatics or blood vessel, whatever it is. I am right in saying that the outer surface is lined by basement membrane, right? That also is the same thing. My cell moves here. Once it moves to this area, let's say it's going to move to this area, the entire area, I'm going to have the same wound healing process happening. So here also I'll have increased collagenase. Once I have increased collagenase, that will destroy the basement membrane also. Once it destroys the basement membrane, it can come easily inside and it can spread. So the step-by-step process of just tissue damage and wound healing. The only thing is tumor cells know it gradually goes, penetrates and destroys the entire structure, fine? So that's what is going to happen in metastasis, and the question is completely based on metastasis. In anywhere when I'm going to have metastasis, the first step is loss of E cadherin. I'm just going to enumerate the steps. The second step is destruction of ECM, extracellular matrix destruction. That's what we saw till now. It's going to destroy slowly one by one. The third step is called an EMT. Expand EMT, anyone of you? EMT stands for an epithelial to a mesenchymal transition, right? That's what EMT is. An epithelium to mesenchymal transition, and you can have this question. There are two genes called as twist and snail. These are two genes which are involved in the EMT process, right? A twist and a snail, right? After that, the fourth step is going to form a tumor emboli. As I said that it will destroy the entire dermis or any stroma. Same mechanism. It will reach my basement membrane, destroy the basement membrane, and enters your lymphatics or your blood vessel, forms a tumor emboli. After that, it will exit via a chemokine. So this chemokine mediated exit is what we are interested much more in future. We'll have a target for that. Once it exits, it's a chemokine mediated exit. Once they exit, they'll go to as a metastatic clone, either in the lymph node or in the lung or in liver, wherever it is, right? So these are the normal steps of meds. And the destruction of ECM, what will happen is metalloproteinase will increase. This will help me destroying the ECM. One of the metalloproteinases is collagenase and gelatinase that will help me destruction of the ECM, fine? E cadherin will be reduced, will not be increased, okay? So just a question, and what you're doing is we are trying to cover the entire topic and related to the question. So it will be a quick revision for you. If at all any question comes in future in the topic, you should be able to answer, fine? Okay, this is a good question. Read the question carefully. I'll give 30 seconds and maybe then we'll write the answer. We'll discuss about the answer. Fine. Okay, the clock ticks. Okay, any suggestions, answers? Okay, SN went for B. Anyone else? Okay, the question is asking about an anaplastic tumor. Which of the following do you think is anaplastic? That's a major question. Let's go ahead. Fine. I'll read the question and then see what's happening here. A 62-year-old woman comes to the physician with the help of lump in the breast. Physical examination forms a removable mass, irregular shaped mass, and mammogram performed, biopsy performed. It's an infiltrated rectal carcinoma. The question is not about the breast cancer at all. The question is asking about differentiation and maturation. Which of the following do you think is characteristic of an anaplastic tumor? See, you must have read about something called as staging and grading, right? B and E with Vishwa, fine. So you must have definitely read about something called as staging and grading. So what do you understand by the term stage and a grade? Which is based on microscopy, which is based on both clinical examination and microscopy. Staging is based on both examination and microscopy, right? It's rather than saying examination, it's actually based on radiology and microscopy only. Right? Via clinical examination, I cannot stage a tumor because when you measure a lump mass, I can say approximately 2 centimeter. Only imaging will give me the exact size, and imaging also will tell me this lymph node is enlarged. Microscopy, I will look at the microscopy and say it's really metastasis. Then my TNM staging will take care of, right? So actually TNM staging is based on the radiopathological correlation, and clinical inputs might help me a little bit, that's all, fine. And grading is purely microscopy. You must have definitely read about a well-differentiated squamous cell carcinoma, poorly differentiated, and a moderately differentiated. We divide squamous cell carcinoma based on the ability to produce keratin. So when I say something is well-differentiated, this is true for any tumor from head to foot. If the tumor resembles the parent cell of origin, I call it well-differentiated. Let's see, a colonic tumor. A colon normally will have glands, yes or no? They will have glands, right? So a tumor forming glands is absolutely well differentiated, right? A tumor forming glands, it's absolutely well differentiated. Or I can change the words and use and say a tumor forming mucin, because colonic glands should form mucin, so they are functionally and structurally resembling the parent tissue, so it's well differentiated. Is then it's anaplastic? No, it is not, right? Hepatic tumor synthesizing bile. Again, yeah, it's coming from the biliary radical, hopefully. It's well differentiated again. It's resembling its function. A skin tumor producing keratin pulse. Skin is squamous cell producing keratin pulse. Again, it's well differentiated, right? So here I have two options here, A and B. Bronchial epithelial cells producing keratin pulse. My first question is it well differentiated or not? Because if I go with the primary structure and function, what is the lining of bronchial epithelium? Bronchus, squamous or columnar? Bronchial epithelium normal lining is a pseudostratified columnar epithelium. So columnar epithelium producing keratin pulse, I might misjudge and say it is not well differentiated, but it's also well differentiated. I'll tell why. Because if you remember, bronchus especially, a bronchial epithelium normally is a ciliated columnar epithelium. That doesn't cause cancer. If you remember the first chapter, what you must have read is, after smoking, repetitive chronic smoking, what happens is the bronchial epithelium changes to a squamous epithelium, the squamous metaplasia. So now tell me, from where the cancer comes, from the ciliated columnar or from squamous? The cancer comes from squamous and not from columnar. And if it comes from squamous, is production of keratin pulse completely normal? It is completely normal, right? So that's also well differentiated. But if I think that it is coming from my ciliated columnar, I will call it a poorly differentiated. So since the metaplasia happens in between, you should not miss that. So don't think it is wrong, it is right. The same holds true for my esophageal adenocarcinoma, secondary to Barrett's. So secondary to Barrett's, if it forms a gland, again a well differentiated. Don't think esophagus is lined by squamous and forming a gland is poorly differentiated, because I have an in-between person called as metaplasia. So all B, C, D and E are well differentiated. So the only one option left is A. Anaplasia. An means absence. Anaplasia is absence of differentiation. In some places we also call it and completely call it as reverse differentiation also. The better terminology is an absence of differentiation. A brain tumor forming giant cells is not differentiated, because normally what happens is a brain tumor can produce glia. The astrocytes, glia, it can produce. It cannot produce anything else, right? If it's producing anything other than that, it's not the differentiation of a normal brain parenchyma. So this is definitely an anaplastic lesion. Okay, it's definitely an anaplastic lesion. Okay, so if it is not producing what the organ should produce, I call it anaplasia. So just for us to understand the concept of anaplasia, when I'm having a medullary carcinoma of thyroid, if it is not producing calcitonin, I call it anaplastic. If it's producing calcitonin, perfectly normal, because medullary carcinoma of thyroid comes from my parafollicular C cells. Granulosa cell tumor, if it is not producing estrogen, abnormal, because the function of granulosa cells is to produce estrogen, right? So that's how we determine my anaplasia. Not only based on the structure alone, sometimes we determine anaplasia based on my markers as well, my IHC markers. I'm sure you know this. Tell me what comes to your mind if you think about breast cancer. What marker comes to your mind when you think about breast cancer? For everyone, for breast cancer, we will use these markers. What are the markers? 3 markers which are very, very famous for every breast cancer. We have ER, PR and HER2/neu, right? These are definitely the 3 markers which are very specific, which is done almost for every breast cancer. So sometimes differentiation can also be done in terms of my marker profile as well. When I say a breast cancer is ER, PR, HER2 negative, triple negative, it's good or bad? See, I'll come to your BRCA1 and BRCA2, those are genetics. So I'm just going to talk about differentiation. ER, PR, all 3 are negative, good or bad prognosis? It's absolutely a bad prognosis. Why I'm saying bad prognosis? A normal breast tissue should be ER and PR positive. If they are negative, I'll definitely call it a poorly differentiated tumor. When I call it a poorly differentiated tumor, I'm going to call it a bad prognostic sign only. Fine. So the differentiation is not always based on my histology alone. It can be based on my IHC also. A B cell lymphoma should express CD19 and 20. It is not expressing bad prognosis, right? So differentiation can be based on my morphology or your marker profile, anything, fine. So I can have the question rephrased by putting all the IHC markers into place as well, fine. Okay. Hope we understood the idea behind your differentiation. And next question is also kind of based on that, fine. So read the question carefully. As usual, we'll give it 30 seconds and then we'll go to the answer. Okay, any guesses? Okay, SN has gone with C. Anyone else? I don't think so. It is C. B, right? Neural and Tong Laurent has gone for B. Fine, great. So now have a look at the question. This is a very simple one. Let's see what we can learn from them, right? I'm having a patient with an 54-year-old person with an enlarged left supraclavicular lymph node showing cells which are positive for keratin. A lymph node should not be ideally positive for keratin. Now here it is positive for keratin. Keratin means cytokeratin, right? It's just cytokeratin. Tell me what are the possibilities, because this lymph node is having metastasis. That's why it's having cells positive for keratin. What are the possibilities this lymph node can have? So I just want you to say me the differential diagnosis. What do you think for this lymph node metastasis? Because I can have many differential diagnoses. Let's see how widely we can spread with just the information of cytokeratin alone. Cytokeratin is a marker for my epithelial cells. Can it be a squamous cell carcinoma? It can be, right? Can absolutely be a squamous cell carcinoma. Can it be an adenocarcinoma of the lung? Possible. They are also cytokeratin positive. Can it be an esophageal carcinoma? Possible. Gastric? Possible. Left supraclavicular lymph node is one side for gastric, right? It's possible for me to have any carcinoma. I'm not saying only squamous. Any carcinoma, it will be cytokeratin positive. So that's the only information I can get it from here. I cannot get any other information from that. I cannot go on specifically diagnose because it's a very sensitive marker, that's all, right? For lymphocytes, it's not cytokeratin positive. As I said that, what marker comes to your mind for every lymphoid tumor? One marker is positive. It's a leukocyte common antigen. What is the other name for a leukocyte common antigen? Don't say LCA. I want the other name for an LCA. We have a CD number for LCA. It is CD45, right? Generally, we use these markers to pick up what is the site of primary. because it's easy for me to pick up site of primary from the biopsy than rather doing a whole body X-ray or a CT scan. Fine. Okay, perfect. For an epithelial surface, as I said, it's CK. If you have any other option, EMA is one more option. EMA stands for epithelial membrane antigen. Nowadays, we have a better marker compared to my cytokeratin, which is BUR-EP4. Okay, when you have BUR-EP4, this is also a marker for an epithelium. This is used nowadays in practice because it's much more better, accurate and crisp than my cytokeratins. Fine. For muscle tissue, I'm going to go with Desmin, because Desmin is kind of positive overall in both smooth and skeletal muscle. If I want for smooth muscle, I go for SME, generally for smooth muscles, and MyoD1 or myogenin for my skeletal muscle differentiation. These are specific markers, but to say it is an muscle origin, Desmin, Vimentin, those are the markers. Fine. For endothelial origin, I am sure you know this. In the inflammation chapter, you must have read about a process called as diapedesis. Do you remember that? Yes. So in diapedesis, what helped in diapedesis? There's a molecule which helped in diapedesis. If you remember, it starts with P. You must have heard about PCAM. What's the other name for PCAM? And I'm sure you know that. The other name for PCAM is CD31. So this is what we read in inflammation, that a PCAM is molecule is going to help in diapedesis. So I'm right in saying that every blood vessel can have inflammation at one point of time, which means every blood vessel should have PCAM. So what I'm going to do is, I'm going to take the PCAM as a marker for endothelium. In other words, any endothelial tumor will be PCAM positive. For endothelium, one of my markers is CD31, right? CD31 is a marker for endothelium. We already know that. I'm going to take it in a different route, that's all. Fine. Okay. So the other one is glial cell. Glia also has a marker. All the glial tumors, including your astrocytomas, gliomas, even your ependymomas, will be positive for a marker called as GFAP. GFAP stands for glial fibrillary acid protein. Okay, this will be positive for every glial tumor. It will not be positive in your meningioma, because meningioma is not a glial cell, it's a meningeal cell, right? So your marker profile is based on the cell of origin. Again, if I know normal, I can easily extrapolate to abnormality. Fine. Okay. Satvik, yes, CD34 can also be seen because CD34 is a stem cell marker. CD34 is not a very lineage specific marker. I can have CD34 in your leukemias. I can have CD34 in soft tissue tumors. It's a stem cell marker. Yes, in endothelial tumors, your Kaposi sarcoma, angiosarcoma, CD34 also will be positive. But 31 is better than 34 because 31 is lineage specific. Fine. Okay. Okay, I'll go to the next question. Let's see. This is a good one. Read the question. I'll give you some time. Maybe then we'll go to the options. The option is the next next page. Okay, I'll give maybe 10-20 seconds. Come to a diagnosis here. Then I'll go to the options. I think the time is enough. Maybe we'll go to the diagnosis. We'll discuss the diagnosis. Then we'll go to the options and discuss about it. Fine. Okay. A 7-year-old kid came brought by the mother with puffiness of eyes. I think your diagnosis would have made by here itself, right? It's a classical case of where did it go? It's a classical case of minimal change disease, right? It's a classical case of minimal change disease with nephrotic syndrome. Only thing I have to prove is whether there's a massive proteinuria. That's all. Yes, 4+ proteinuria for sure. 4 gram per liter. Yes. Urinary protein, and the patient has a serum albumin which is less, right? Everything is perfectly fitting into one minimal change disease, which is a nephrotic syndrome. So the only thing I want you to know is keep this in mind. Based on that, we'll go to the options and tell me which of the following is correct in this patient. That's all. The diagnosis is minimal change disease, nephrotic syndrome. Based on that, I need an answer, right? I'm going to the answer. 10 seconds. Read the options and tell what will be the correct. Okay, what do you think is the correct answer? It's a patient with a nephrotic syndrome, like you guys said. Okay, SNS opened the account, and it's E. Anyone else? C, neural. B. Okay, C. Okay, we have lots of things here. Okay, great. Fine. I'll go with the essence answer. E is the correct answer. I'm sure why you have marked as C as the right answer. I'll have a thing. Yeah, perfect. Like Nurel said that loss of 83 will be there, antithrombin 3. So a nephrotic syndrome patient undoubtedly is at a risk of thrombosis. I'm just going to go up. Fine. Okay, cool goal has gone for A. I'll go up. Is there any evidence of thrombosis in the question? The patient has no thrombosis or no symptoms suggestive of thrombosis. If the patient doesn't have thrombosis, do I need to give prophylaxis? Yes or no? I need not. If the patient has an episode of thrombosis, I'll treat the patient, then I might give prophylaxis. If the patient doesn't have thrombosis, this is not required. Thromboembolism happens, but it doesn't require prophylactic anticoagulation. I will treat them. I can't keep on giving antithrombin 3 or prophylactic anticoagulation for every patient with minimal chain disease or a nephrotic syndrome, like everything is self-limiting. It's not required. If the patient has thrombosis, for sure I have to treat, then maybe I'll look for the prophylaxis, not before that. Since this question, the patient is not having thrombosis, I'm not going to give that, fine. Spontaneous bacterial peritonitis doesn't happen. That happens in ascites. It's not going to happen in a nephrotic syndrome. Urinary loss of calcium is not a problem. Acute renal failure is not generally a problem because minimal chain disease is a very, very self-limiting condition. Proteinuria and puffiness is the important thing. Symptomatic management, most of them will come back to normal, right? So the only left option is E. E is the correct answer, but I have to know why E, right? I'll just ask you a question, a leading question. Tell me what all things which can be lost in urine in nephrotic syndrome. Apart from your urine, your albumin, do you know anything which can be lost in urine? Your antithrombin 3, like Nurul said. Anything else? Can I lose fat in urine? Yes, absolutely. I can have lipiduria. I can use fat. So you can have fat loss. And one more thing which can be lost along with this is transfer. It's a very, very important thing. This generally we don't read about it much, fine. In a nephrotic syndrome patient, transferrin can also be lost in urine. Once transferrin is lost in urine, even in spite of me having an adequate iron intake, will my erythroid get the iron? They can't, because there is no transferrin to carry the iron from the duodenal epithelial cell to my erythroid. So once transferrin is lost, the patient will definitely have an IDA, iron deficiency anemia. So for this patient with iron deficiency anemia, if I give an oral iron as treatment, the patient takes an oral iron, duodenum absorbs. Can it go there? Yeah, immunoglobulins also will go. Can it go to my erythroid? It cannot go to my erythroid, right? So what the option says is microcytic hypochromic anemia, absolutely correct, and poorly responding to oral iron, because oral iron, again, there is no transferrin. So there is no transferrin, it cannot happen, right? So the only treatment in this condition, if it's a long-standing case of nephrotic syndrome, either go for parenteral iron therapy or go for a blood transfusion. That's the only possible way to treat anemia due to nephrotic syndrome, which is a complication in chronic cases. Like FSGS patients might have this trouble, right? That time I might be required to treat them differently, that's all, okay? Generally, it will not happen in minimal chain disease, but this is definitely a possibility. If the patient has microcytic hypochromic anemia, it will poorly respond to oral iron therapy. That's a complication for any nephrotic syndrome, fine? And again, keep this in mind. We had a question yesterday in the Unacademy app when we were discussing about coagulation. There I said give antithrombin 3 because the patient presented with thrombosis. Based on the clinical presentation, I will treat. I will not give prophylaxis, fine? The next one. Again, I'll give you 30 seconds. Read the question and comment on the answer, then let's go ahead. Okay, I've got two answers, C and B. Anyone else? Okay, C again. Sure, Sonal. C again. Fine, we'll go and read the question and see what will be the answer. A 45-year-old with 2 weeks of persistent back pain. She also had an extensive fatigue, anorexia, unintentional weight loss over the past several months. So most likely a malignancy. The patient has no prior history of cancer. Imaging shows a light depletion of the teeth and vertebra. Sample shows an abnormally high replicative potential. That's all. I'm not bothered about what disease it is. I'm having a vertebral lesion which has an abnormally high replicative potential. So it's a cancer. My question is, which of the following do you think is responsible? Which of the genetic study shows a single nuclear substitution causing an activating mutation? Which of the following is the most likely gene? See, in the entire thing, what is more important, what is the only thing which I'm bothered about is the activating, right? The activating is the one which I'm really bothered about. I'm not bothered about anything, right? Perfect. It's an activating thing. It has to be a proto-oncogene. Like Nurul exactly pointed out, APC, BRCA, Retinoblastoma, T53, all of them are tumor suppressor gene. So every tumor suppressor gene should have a loss of function mutation only. Like we saw in the first thing, should have a loss of function mutation. The only one thing which is in proto-oncogene here is this, right? Proto-oncogene will have a gain of function mutation, right? So I'm just going to give a different perspective here. See, we already know about your proto-oncogenes and tumor suppressor genes, right? You also know that, like you guys said, that every proto-oncogene I'm going to have a gain of function mutation. So let's say that one X amount of protein is elevated. Can I produce an antibody to that protein and destroy the protein? Possible? Not possible? Possible? Yes. So when I have a gain of function mutation, there's increased amount of any set product. So the only easier way to treat for me is produce a monoclonal antibody against it and I can destroy it, right? So this is a way for me to understand. It's reverse learning. Because what we know is, we know many monoclonal antibodies, trastuzumab, antibodies to HER2/neu, which means HER2/neu should be a proto-oncogene. Vemurafenib, BRAF antibodies, which means BRAF should be a proto-oncogene, right? I know the drug name, I know the target also, which means I know which are proto-oncogenes, right? So anything, when you have any cancer with a monoclonal antibody, most likely the gene which is getting targeted will be a proto-oncogene only. Okay, you can just reverse, and this is called as an oncogene addiction. We have a term called as an oncogene addiction, which means the entire cancer is centered around this, like your BCR-ABL for CML. The entire cancer is fueled by my BCR-ABL gene product. So when I gave imatinib, I was trying to stop the BCR-ABL gene product. The entire cancer will die. That's called as an oncogene addiction. So whichever gene undergoes oncogene addiction, that's very good for me. I have a treatment, I have a targeted therapy, good prognosis. The only problem with KRAS or any RAS is RAS will not fall under oncogene addiction. I was not able to create a drug for long. 2020 is when we created a drug for your RAS, and in late fag end of 2020, the drug also became resistant. So whenever any cancer, if it has RAS mutation, good prognostic sign or bad prognostic sign, because I don't have a targeted therapy, a fully functional targeted therapy, all the RAS mutation will have a bad prognosis only. It will not have a good prognosis. Everything will have a bad prognosis, right? We can just extrapolate with tiny information and to a bigger concepts, and we can reduce our burden on the memory. Fine, great. So we'll go to the next question. Again, same thing. Read the question and give the answer, then we'll go ahead. This is a very simple one. I'll not be discussing much on this question. Just tell the answer. We'll finish it soon. Okay, answers. I've got E as an answer. SN has answered E. Any other guesses? It's a simple one, right? What's the diagnosis here? The primary diagnosis, whatever it's been concentrated upon, the patient has muscle wasting. That's a main problem for me here. It's cancer cachexia, right? We are discussing about cancer cachexia. They have a 10 kg weight loss and muscle wasting, and everything about cancer cachexia is due to inflammation, primarily mediated by tumor necrosis factor. As the name says, it's tumor necrosis factor and it's cancer cachexia, right? We're not going to discuss much about this. This is a very straightforward, easy one. We have discussed about this amply, right? Next question. Okay, again 30 seconds. Your time starts. Okay, guesses? C. Nurul and Doc Sumit is C. Anyone else? Okay, SN also goes for C. Okay, great. See, here it's early adenoma and late adenoma. Fine, this is what is basis for my adenoma carcinoma sequence. Generally a normal adenoma carcinoma sequence, the first one to be lost for me is APC. Then your CCND1 comes, which is my beta catenin, right? So beta catenin will not be the general one for early and late adenoma. Like you guys said that for me for early adenoma to a late adenoma, again it's late adenoma, the features, the thing should be loaded as KRAS. After this late adenoma to an adenocarcinoma, I'll have a P53 loss. When carcinoma has to undergo metastasis, generally what is the final step? It's common for almost every cancer. It has become a cancer, it has to spread and it has to kill the patient. One thing, if it is gone, I know that this cancer is going to become haywire. The last step generally will be your telomerase activation. Okay, this is true for everything. Telomerase activation will be the last step before it can go haywire and it can cause multiple metastasis and I can lose the patient as well. Yes, based on adenoma carcinoma sequence, from an early to a late adenoma, the one is going to be altered is my basement membrane invasion happens before cancer itself, right? When it becomes cancer itself, is basement membrane invaded. To make it metastasis, I need telomerase. And here the answer is your KRAS. Okay, fine. Next question. Again a 30-second break and answer it. Okay, any other guesses? SN went for cytochrome C. It's a very simple question based on the first chapter of cell injury and cell death. Okay, C again. Fine. So fine, let's go and look at the question. A 46-year-old Caucasian female has a growing neck mass after initial evaluation. Chemotherapy was given and the patient has many shrunken eosinophilic cells within the tumor. Which of the four substances released from the mitochondria has triggered the observed changes? See, based on this question, tell me, ignore this mitochondria, ignore the last line. So based on this question, the tumor is undergoing apoptosis or necrosis? It's apoptosis or necrosis? It's apoptosis. How did you say it's apoptosis? And eosinophilic mass, can that be necrosis also? Necrosis also will have increased eosinophilia, right? They will have increased eosinophilia, absolutely. So what made you to say it's apoptosis? Unless the last point will help me to think about apoptosis, the mitochondrial release. The thing which will lead us to apoptosis is my shrunken cell, right? In necrosis, the cell will be swollen or shrunken. It has to be swollen, right? When I have a cell which is shrunken, I'm going to think of an apoptosis only, right? So it's a shrunken cell, so it has to be apoptosis. So now it becomes very easy, simple for her. We have two types of apoptotic pathway, the initiator ones, your extrinsic and intrinsic. Here the question is on intrinsic because it released from the mitochondria. If it is extrinsic, what will be the answer? Same thing, I'm saying that instead of mitochondria, based on cell membrane, something is getting activated. The answer will be option B, right? Option B is my extrinsic pathway of activation. Cytochrome C is my intrinsic pathway of activation. Both will cause and lead to an apoptosis. The initiator pass, then it goes to execution path. In execution path, you'll have your caspase 3, 6 and 7 activation. You'll have your endonuclease activation, which will then be eaten by phagocytes. This phagocytosis after apoptosis has a unique name. What was that? That was kind of an update in the 10th edition of Robbins. It's not just another name, it is lots of implication about the name and about the pathogenesis. What did we call that? We had a new name for this type of phagocytosis. We call them, I'm sure you know that, you must have heard that, called as epherocytosis, right? See, epherocytosis is very, very important and we are researching lots about epherocytosis. Tell me if I'm right in saying this. When I'm going to have macrophages coming and eating in an area, will there be inflammation? Yes or no? There should be inflammation, right? Because macrophage cannot come just like that and eat it. Because whenever macrophage eats something, macrophage automatically will become activated and will start the wound healing process, and it should always end up with fibrosis. That's what we know, right? So here, this efferocytosis is so unique that it's also macrophage mediated phagocyte of the apoptotic cell, but doesn't elicit inflammation. No inflammation, no wound healing. That's why it is very important. I'm understanding more about how my macrophage can silently eat as well. If I'm able to understand it, if I'm able to replicate it, I can use the same process for me to eat tubercle bacilli. If I eat the tubercle bacilli without any inflammation, will it cause granulomas? It won't, right? Will it cause tissue destruction of your fibrocavity lesion? It won't. The main problem in every chronic inflammation is not the etiology, it's the macrophage. The macrophage and my immunity cause the destruction. So macrophage also knows to eat silently. That's why efferocytosis became a big one, and we are learning much about efferocytosis. We are trying to apply that to your tumor related cell death also. Hopefully in future we'll have some answer for that. Fine. Okay. Next one. Again, this is a good question. Read that and give me an answer. Okay, guesses? Okay, B and C by SN. Anyone else? C Vishwa again. It's a simple one, right? It's also based on a very simple concept. I'm going to dig with a very basic thing of inflammation, and we are talking about only one person, the ESR. Here, ESR is elevated. The question is indirectly asking which of the following is responsible for my elevated erythrocyte sedimentation rate. The answer is my interleukin 6, right? Serum levels of which of the following substances most likely seen with the above finding. A raised elevated ESR, it's inflammation, and inflammation is interleukin 6. So what interleukin 6 does is, it increases many proteins. One of them is fibrinogen. Once fibrinogen levels are elevated, what they are going to cause is, they'll make sure normally my RBCs will have negative charges. That's why they repel each other. Inside the circulation also they repel. When I catch them and keep outside also they'll repel. This fibrinogen will neutralize the charge. This charge in the RBC is called as zeta potential. This can also come in an MCQ. The zeta potential will be neutralized by my fibrinogen. Once it neutralized, it will allow them to sediment. Okay. So when I'm having increase in fibrinogen, the sedimentation will be faster, right? We'll have a faster sedimentation. When there's a faster sedimentation, obviously the rate of sedimentation, ESR, will become elevated. Fine. It's a simple question, right? I don't want you to do ESR whenever you start to practice, because ESR is a very outdated thing, and I will not be able to do it with confidence, and the repeatability of the test is very less. So please don't do ESR. If at all you want to evaluate a patient for inflammation, please go with CRP. Fine. So the same thing, if interleukin 6 is responsible for inflammation, am I right in saying that any disease, when I have more interleukin 6, I can have the same problem? Yes. I'm having a disease where I'm going to have interleukin 6 like 5-10 times more than normal, or 5 times more than inflammation, right? So the disease what you're talking about here is multiple myeloma. In multiple myeloma, interleukin 6 is the one which increases the proliferation of the neoplastic cells as well. Okay. But if it increases in multiple myeloma, ESR will be elevated. That was used as a prognostic factor long back, right? The same thing, if it is 5-10 times more than normal, am I also right in saying that the RBCs can sediment even without having a normal undisturbed column? It will also fall one on top of the other even inside my blood circulation, right? So because of this, there will be an increase in RBC sedimentation. This is what we saw in the peripheral smear also, and we call them a stack of coins. We call them a rouleau formation. Okay, so that's just a rouleau formation. Okay, it can result in rouleau. So if this is correct, am I right in saying that a sepsis can also have a rouleau formation? The sedimentation which happens inside the body or in a peripheral smear, I call it rouleau. Can a sepsis have that? Absolutely yes, right? So rouleau is not specific for myeloma. Rule means inflammatory markers are more, interleukin 6 are more. It can be seen in sepsis, inflammation related. It can be seen in myeloma also. Fine. This question is on ESR and interleukin 6 is the answer. Fine. Let's go to the next one. Okay, read the question carefully and tell the answer. Then let's go ahead and discuss about it. Okay, any guesses? Okay, MMV Nadu went for C and SN went for B. Anyone else? Okay, Noodle for B as well. Papillary. Okay, we'll come to the diagnosis of papillary first. First, I need the diagnosis here. A 45-year-old person having a neck lump, something related to thyroid, I'm sure that. I'm just going to go for the diagnosis, right? Santhan as well as Noodle went for medullary carcinoma thyroid. The FNAG shows a nodule with spindle-shaped cells with an amorphous background, right? Amorphous pink background is your amyloid. Not only that, I have one more hint. Serum calcitonin levels are elevated. So I'm thinking of amyloid and elevated serum calcitonin levels. So my primary diagnosis here is medullary carcinoma of thyroid, right? It's not papillary carcinoma thyroid, right? Let's have medullary carcinoma thyroid here. So which of the following will be abnormal in medullary carcinoma thyroid? See, ALK no, P53 no, BCL2 no. Those three are out of the question. So my thing here is it inactivation of MEN1 or my RET, right? MEN1 will cause medullary carcinoma thyroid, or MEN2 and 3 will cause, MEN2A, 2B will cause medullary carcinoma thyroid. It is MEN2A and 2B, not your MEN1, right? So it's MEN2A and 2B, and they'll have an activation of RET proto-oncogene. If it's syndromic also, if it's sporadic also, right? Both of MEN2A as well as 2B can cause medullary carcinoma thyroid, and both of them is activation of your RET proto-oncogene, fine? So the same RET proto-oncogene can also get inactivated or your loss of function mutation. In your medullary carcinoma thyroid, they'll have gain of function mutation. Same with MEN syndrome as well. Loss of function mutation of RET proto-oncogene. Which disease? That's also one related disease. Which disease will have that? Loss of function mutation will be seen in Hirschsprung's disease, right? In Hirschsprung's disease, it's lost. When RET is lost, there was a defect in the transport of the neuronal tissue. That's why in Hirschsprung's, because of the defective in the transport, I don't have enough plexus in your myotonic and mesenteric plexus. That results in an aganglionic colon, right? Loss of function of RET causes Hirschsprung's. Gain of function of RET causes tumors, MEN associated or in sporadic tumors as well. Pheochromocytoma can also have red mutations, fine? Okay. Next one. Okay, and read the question carefully. Give an answer and let's go ahead. Okay, SN has started with E. Anyone else? DVT, E. Okay, most of you are going with E. Okay, what's the diagnosis here? Can DVT happen in left femoral artery and cause a thrombus and cause the ischemia and everything? It's not, right? So maybe a thrombotic event here, and the patient has a left calf pain on repeat examination after several hours. So I'm having a destruction here, a reperfusion related injury, right? So this question is dealing about reperfusion injury, and all the reperfusion related injury are due to my reactive oxygen species only. We must have read about reperfusion related injury in detail in myocardial infarction. It's not just in myocardial infarction. Wherever there is an ischemia, if I have to give back the circulation again, it will cause injury. Let it be your toe in toe, in your heart, in brain. It's the same thing. The only difference may be the critical time. The critical time will vary for my stroke and for my MA and for the peripheral organs, right? So everything, if I'm going to give it back, it might cause a damage. Reperfusion injury, embryological injury is due to reactive oxygen species. Of these four, none of them can neutralize the toxic effects. The only thing which can neutralize here is superoxide dismutase, which is a free radical scavenger, or it's an antioxidant, right? It's an antioxidant. It will help me for sure to remove the reactive oxygen species, and it sometimes maybe I'll be able to reverse the damage also. It will not be, but maybe I'll be able to reverse the damage, right? Theoretical question, antioxidant is the right answer, right? Okay, next one. Read the question carefully and give an answer. Okay, anyone else? It's a very simple question. A 73-year-old person with the emergency department with a history of hemiplegia. So Anthan went for D, SN went for C. And the question is simple. What do you think must have happened in the patient's brain? If I have to rephrase the question, I have to ask what type of necrosis you will see in your brain. That's all. Brain, in fact, will have a classical type of necrosis that I'm sure all of you will know. It's a liquefactor necrosis, right? It's a liquefactor necrosis which happens in the brain, and liquefactor necrosis, hydrolytic enzyme induced tissue destruction. The mechanism of action for liquefactor necrosis is not protein degradation, it's activation of enzymes, right? I can see liquefactor necrosis in brain, in fact. I can see them in abscess cavities, that's more important, and I can see them in wet gangrenes. Abscess cavity is more important because that's more realistic. I will not get a brain biopsy during a stroke, but yes, I'll get lots of abscess tissue biopsies. So abscess also will have liquefactor necrosis. Accumulation of fibrin-like material in the blood vessel. Option A, what type of necrosis? Option A also is a classical type of necrosis. What type of necrosis is that? Option A is blood vessel, fibrin-like material. Like is oid, so it is fibrinoid necrosis, right? So where do you see fibrinoid necrosis? As the name says, it's fibrin-like. When will I have fibrin? In my body, when will you have fibrin? You'll have fibrin when you have a blood clot. That's when we'll have fibrin. And again, in other words, when will I have a blood clot? When my vessel is damaged. When I have a cut vessel, I'll have a blood clot. In other words, any pathogenesis in my body, if it's going to affect my vessel, I'll have fibrinoid necrosis. It can be vasculitis, it can be a malignant hypertension, right? It's not just PAN or rheumatic heart disease, anything which affects my blood vessel. Any vasculitis, any malignant hypertension, any type 3 hypersensitivity, circulating immune complex causes vasculitis, right? RHD, it also happens. It's not just RHD. Heart is considered as the biggest vessel. So anything which damages my endomyocardium will cause this. Fibrinoid necrosis means it's a vessel wall necrosis, that's all, right? Formation of necrotic foci surrounded by epithelial macrophages. What pathogens are we describing in option B? Today in an INICET also you had Ashoff bodies, right? Option B, what are we discussing there? It's just nothing but a classical explanation of a granuloma. Both necrotizing as well as non-necrotizing granuloma, I want you to think of only one person. Yeah, tuberculosis, fine. Amazing elderly, it's fine. We'll learn from it, and maybe your cutoff will reduce if the paper was tough, fine. Let's always think of tuberculosis as granuloma. Unless and otherwise disproved, it's something else. First, obviously tuberculosis, both for necrotizing as well as non-necrotizing granuloma. Never sarcoidosis. Sarcoidosis are always the last. Deposition of fatty acid and calcium complexes. What type of necrosis are we talking about here? Necrosis in fatty acid. We are talking about, as the name says, we are talking about fat necrosis, right? The only place where I am worried about fat necrosis is not my pancreatitis and the omental calcification of fat. A pathologist doesn't require that, right? The only place where I need fat necrosis is your traumatic fat necrosis. It happens in any structure which is rich in fat. especially your breast parenchyma. Because in breast parenchyma, when you have calcification in a mammography, it's one of the differential diagnoses for DCAS and a malignancy. So it becomes sometimes difficult to differentiate them, and a mammogram can give almost a near conclusion, but I need a biopsy. If there's any suspicion of a microcalcification in mammogram, do a biopsy to rule out cancer, because fat necrosis can also cause calcification, so I might have a confounding factor there. Fine. Tissue necrosis with preservation of cellular architecture. What type of necrosis is this? Option E. Option E. What type of necrosis? A preservation of cellular architecture always goes for your coagulative necrosis, right? It always goes for coagulative necrosis. This preservation of cellular architecture was given one more fancy term. It was called as a ghost cell. So in other words, I can ask you maybe one more question saying ghost cells are seen in which type of necrosis? Again, coagulative. It is not seen in liquefactive, but it will be seen in coagulative for sure. Fine. So we had all the 5 types of necrosis discussed in a nutshell. Fine. Next question. Okay, it's a good question. Read the question and give an answer. Okay, Santhan and SNS went for A. Anyone else? Anything else? It's a very simple question. I'm having a diagnosis and I wanted to find something similar to that diagnosis, right? Everyone went for it. Perfect. What's the primary diagnosis here? It's Barrett's esophagus and it's metaplasia, right? The primary diagnosis for me here is Barrett's esophagus and a metaplasia. So the question is simple, asking which of the other following things will fall into metaplasia. Obviously, a bronchial epithelial cell in a chronic cigarette smoker, just now we saw, it's a metaplasia. It's squamous metaplasia, and GERD will have columnar metaplasia. Fine. We'll look at the other process. An epidermal cell in patient with psoriasis. I want the answer in terms of cellular adaptation, not anything else. What cellular adaptation happens in option B? Option B has one classical cellular adaptation. What is that? It'll have hyperplasia, right? In psoriasis, you'll have papillomatosis, you'll have epidermal hyperplasia, your parakeratosis, everything is hyperplastic, right? Option B will have hyperplasia. Option C, melanocytes in a large irregular mole. What will happen? Which of the cellular adaptation I can go for? Option C. If I'm going to consider it as a melanoma, because the irregularity, I might think of an dysplasia, maybe, or if it's a mole, I can still think of an hyperplasia, right? I do want to see in the microscopy what is the exact diagnosis. If it is irregular and if it is in cancer, I might go for dysplasia. If it is not, I might go for hyperplasia. It's totally based on it. Since it's given irregularity, I will lean towards a dysplasia and a neoplasia. Fine. Option D, myocardial cells in patient with aortic stenosis. What cellular adaptation is here? It's clear. Myocardial cells can undergo hypertrophy, right? They have a classical cellular adaptation which is going to undergo hypertrophy, right? Perfect. Great. Option E, skeletal myocytes after prolonged immobility. What will happen here? There's also a cellular adaptation. See, all of them are related to cellular adaptation. The only good thing about your MLE questions is I can have one question and I can discuss everything related to that, right? It's a disuse atrophy. Perfect. Okay, it's a disuse atrophy. If you have good amount of time, if you're giving this NEET exam, I would not ask you or recommend you to do a new world. If you're giving maybe 2023 or 24, if you're still in your professional years, please go with new world questions. They are really, really good. I can understand the entire topic with a single question. Fine. Next. Okay. Read the question and give an answer. 30 seconds. Sure, Ranjith, I'll do it. Okay, the first one person to take the bait is SN again. Option C. Okay, we'll go for option D next. Anyone? Cyanthan is for C again. E. Psoriatic arthritis. Okay. Great. Anyone else? C. Fine. We'll go and read the question and see what will be the correct answer. A 32-year-old person having a primary care provider having a psoriatic flare. So the entire thing is in the first line itself, right? Psoriatic flare is that the patient is having psoriasis and the patient also having arthritis, right? Whatever it says, hands are stiff, sometimes use a finger, everything is there. Physical examination reveals a block and a Silbury scale. So the patient is having a psoriatic lesion and the joints are mildly swollen and nail or the bone has been splitted. Which of the following is the most likely pathogenesis? Psoriatic arthritis, its activation of the RANKL pathway is related to the pathogenesis of psoriatic arthritis. This is not option C. What will be the disease with option C? It is your classical rheumatoid arthritis, right? I won't have anything here. So there's no history suggestive of rheumatoid arthritis here, so I'm not going to go for rheumatoid arthritis. So classical psoriatic arthritis, answer is option E. What will you think of option A? What disease will fit into option A? Option A is classical. It's an invasion of the organism. It should be a septic arthritis. Okay. Septic arthritis in a child could be anything of that sort. Right? The septic arthritis is for option A. Option B, a repetitive injury. A repetitive injury is like a lifestyle change. Most likely, repeated damage to joint might cause an osteoarthritis. The main risk factor of osteoarthritis is the weight, right? It can happen, right? Okay. And deposition of crystals in the joint space could be either gouty arthritis or a pseudo gout. Based on the history and the joint involved and the crystals deposited, I can differentiate all of them, right? So here my diagnosis is psoriatic arthritis, and psoriatic arthritis I'm going to have release of tumor necrosis factor in this. Yeah, gout for option D. Perfect. So we'll go with whatever Ranjith asked. Eccentric and concentric hypertrophy of heart. See, the only way you're going to remember things for a longer time is you have to relate it to a real life situation which you already know, and those analogies should be very, very simple. I'm sure all of you must have played with balloons. That's a very common thing what we must have done, right? And we are going to compare how a balloon reacts to the heart in an eccentric and a concentric hypertrophy. If you have filled a balloon, I'll just go to this thing, I'll come back to the others. I just want an empty space, that's all, right? Let's say that I have a balloon like this. I have filled water into a balloon and I am filling air into a balloon. Simple things. When I fill water into a balloon, the balloon will become like an oblong shape, right? It will become like this, right? When I blow air into a balloon will become kind of circular or oval, whatever it is. In other words, air in the room you are sitting, all the corners of the room also, the pressure will be the same. That's the property of air, right? Or the property of a pressure. The pressure here will be equidistributed. So I'll have a pressure which is equally distributed. So my heart, if that is heart, I'll have the same way, right? It's a pressure hypertrophy. And I'm going to have a pressure hypertrophy secondary to hypertension. Maybe I'll have an all over, I'll have pushing effect, all over it will react back, and I'll have a concentric hypertrophy of heart. So concentric hypertrophy of heart is due to pressure. Everywhere I'll have hypertrophy. When I say due to volume, let's take an aortic regurgitation. When the heart pumps, half of the blood goes to the aorta, rest half comes back again. That's volume, right? So when the volume is there, like a water inside a balloon, volume will always go to the dependent part only. So when I'm having more pressure in the dependent part will react more compared to the non-dependent part. So I'll have an eccentric hypertrophy of heart. So eccentric hypertrophy of heart will happen in conditions with an volume overload. When I have conditions with an volume overload, which will be maybe secondary to an aortic regurgitation. If I'm talking about my left ventricle, right ventricle maybe tricuspid regurgitation, or in my pulmonary regurgitation, right? Based on the ventricle and the atria, the logic is the same. Anything due to volume will have an eccentric hypertrophy. Anything due to pressure will have an concentric hypertrophy. Fine. I hope it is clear, Ranjith. Fine. Okay, I'll go to the next question. Okay, yeah, I think this is the next one. I'll give you 30 seconds and Okay, answer. It's a very simple one, right? Okay, again, let's open the account. We shouldn't make a mistake in this question. This is one of the things which have been born and brought up with, right? It's our disease which is very, very common, and I hope everyone in future should not miss. Never a case of tuberculosis should be missed. Whatever it may be, wherever it is going to present, from head to foot, I should be able to pick up case of tuberculosis, right? A patient with chronic cough for 1.5 months, night fevers, loss of weight, and the patient has diminished respiratory sound, base of lung, everything, has an opacity in the right apex. My diagnosis is one and only tuberculosis. Fine. Okay, it has to be one and only tuberculosis. The answer is a straightforward question. It's just put out there to convey the message. Please don't miss case of tuberculosis. Wherever you are posted, whatever specialty it is, TB should be diagnosed with confidence. Fine. Okay, the next one. Whatever questions I am taking are from UWorld. Most of the questions in UWorld, when they are going to take an infectious disorder, they'll give a recent trip to another third world country. That's all. Fine. Great. Again, it's a simple one as well. It's a classical case of an MI. The question is asking which of the markers is most specific and will remain elevated for a week after the acute event. Specific marker, there's only one marker which has to be troponins. There's nothing else which is as specific as troponin. I'm not going to comment on what is the marker useful for reinfarction. See, I know my limits. The reinfarction marker should be commented by a cardiologist and not by a pathologist, right? So go ahead with whatever your cardiologist says or your medicine person says. The marker for reinfarction, go for that. But specific for an MI has to be troponin, nothing else, right? CKMB is decent, but definitely not the specific one. Okay. Next one. It's a good question as well. Read the question and come to the answer. Great, because they're becoming faster and faster as the time goes, right? So the classical case of celiac syndrome. The patient is having a defect in the phagosome fusion with the lysosome. What gene will be mutated in celiac syndrome? We have a specific gene which will be mutated. The gene to be mutated, we have a gene called as LYST gene, right? That's a gene mutated in celiac syndrome. It's an autosomal recessive inheritance. The primary defect is in the phagolysosome fusion. This LYST gene is one gene which is responsible for the fusion of phagolysosome. It's LYST stands for lysosomal transporter. T for transporter, right? So LYS for lysosomal and T for a transporter. So the thing about celiac is it's not just the infection. Infection will be present. I have lots of immunodeficiency disorder. What makes them stand out from other immunodeficiency disorders? This transporter is not only responsible for my phagolysosome fusion, they have other functions as well. This is the same transporter which is going to help my, what is the origin of melanocytes or embryological origin of melanocytes? They are not epidermal derivatives. Melanocytes come from my neural crest origin. So from my neural crest, it has to come to my tip of finger. It has to migrate. So this LYST gene is responsible for my melanocyte migration. These are the normal functions. So when melanocytes are not migrating properly, the patient of celiac syndrome will have albinism. That's one of the classical features which might differentiate from other immunodeficiency disorder, right? Not only that, you must have definitely known about a cell which helps in the myelination of peripheral nervous system. Peripheral nervous system will be myelinated by my Schwann cell. Schwann cell also same, the origin is neural crest. So something coming from neural crest origin has to come from the tip of my finger, nerves, right? Same thing, they also help in my Schwann cell migration. So for my Schwann cell migration, if I require celiac syndrome, if I require LYST, in celiac syndrome, I won't have a perfect Schwann cell migration. So the patient might end up in a peripheral neuropathy. Again, it's not always, it's a dictum to have, but they can have a peripheral neuropathy. Right? That could be one of the symptoms. Okay. You must have seen platelets in your microscopy, right? What do you think will be the shape of platelets in a microscopy? In a microscopy, generally we draw platelets like this, and we draw them tiny round cells like this. Actually, they are not round. They are round in circulation, but we call them platelet. It's like a plate, right? Let is something precursor. Platelet is plate-like shaped precursors. They are round generally, but when they want to act, let's assume I'm having a tiny injury like this. A round cell cannot go and bind in the injury. It's much more logical for me. The round cell becomes like a flat plate and goes and binds, so that sealing will be perfect, right? So for my platelet to have function, they have to change its shape. For this change of shape, again I require LOST. So in a celiac syndrome, I will have patients might suffer from thrombasthenia, not thrombocytopenia, primarily thrombasthenia. My function is abnormal, fine. So a few things which can be changed with celiac syndrome. Do remember this. So this helps me to differentiate from a classical immunodeficiency disorder. There are lots of immunodeficiency disorder from celiac syndrome. These are a few things which can help me, fine. Okay. The next. Okay, this is a very simple one. Read the question and give an answer. It's D. See, heart failure cells are not from pneumocytes, they are macrophages, right? So when the patient has a heart failure, there's a negative pressure, the patient might have a pulmonary edema. When there's a pulmonary edema, the macrophages are going to eat them, swallow them, and these macrophages are called as heart failure cells. One of the commonest mistake you might do if you're in a hurry, heart failure cells are not seen in my heart, they are seen in lungs. Okay, you will definitely know this, but in a hurry, don't write they are seen in heart, they are seen in the lung finding. And they are hemosiderin laden macrophages. So what stain will I use to identify them? They are hemosiderin. So I have a stain which will be positive in iron. The stain is which will stain iron, my pulse Prussian blue, right? So these hemosiderin laden macrophages will be positive for a pulse Prussian blue. A pulse positive macrophage in the lung, you have to think of an heart failure cell, fine? Okay. Okay, the next question. Read the question, look at the options, and then give an answer, fine? 30-second gap again. Okay. If you have a difference of opinion between D and A, okay, A again, B, fine. So see, the question is asking about a familial deficiency of clotting factor 7. Clotting factor 7 is involved in extrinsic pathway or intrinsic pathway or common pathway. If you know that, my diagnosis, my answer is almost set. A clotting factor 7 is a clotting factor involved primarily in my extrinsic pathway, right? It's going to involve in extrinsic pathway. The investigation which will be getting altered is my prothrombin time. So it's a factor seen in my extrinsic pathway. When it's an extrinsic pathway, what will be elevated is classically prothrombin time will be elevated. My activated partial thromboplastin time is going to be, or your PTT or APTT, both means the same, right? If you're confused because of that, ignore it. Partial thromboplastin time and activated partial thromboplastin time means one and the same. APTT will be elevated in intrinsic pathways. Factor 7 doesn't happen in intrinsic pathway, it's only in the extrinsic pathway. So obviously option A of prolonged PT and a normal APTT will be the thing which will be seen here, fine? Okay, that will be the findings in your factor 7 deficiency. See, a congenital deficiency of factor 7 is an extremely rare condition, but I want every one of you to remember this in mind. PT can be prolonged. That's one of the first factors which will be lost in liver failure. When I'm having a patient with an early onset liver failure also, my PT will be prolonged. Factor 7 will be knocked off very early and PT will be prolonged. I want you to remember this forever. Why I'm stressing this is for any investigation, invasive investigation in the abdomen, be it a liver biopsy or a renal biopsy or anything, or even putting into a laparoscope, anything, I need PT to be normal. If you remember liver function test, PT is one of the components of them, right? If PT INR is not normal, please don't do any intra-abdominal or any invasive procedure for that matter, not even a bone marrow aspirate. It will prolong it. I'll have a problem, right? So PT has to be normal. If PT is prolonged, which means your clotting will not happen perfectly. So if I take a liver biopsy in a patient with a prolonged PT, I have a chance of having an intra-abdominal hemorrhage, which cannot be stopped. I cannot compress it and stop it. I need to open the abdomen, which might become catastrophic at some point of time. Any invasive procedure, keep this in mind forever, you have to look for PT, and PT should be absolutely normal. If it is not normal, correct the problem and then do an investigation, fine? This is one prerequisite required for every investigation, okay? The next one is a good question. Read the question. Each one of them actually conveys a message for us, fine? Tell me the answer. Answer? Okay, Santa has gone for D. Happy Dr. D. Everyone is going for D. Fine. Great. Let's go and have a look at it. The question is a very, very simple one. Which of the following is an aneuploid karyotype? We'll look at the answer for sure. We'll look at every option. A reciprocal translocation between two acrocentric chromosomes. What does this mean? A reciprocal translocation between two acrocentric chromosomes. This means only one finding. This is your classical Robertsonian translocation, right? It's a classical Robertsonian translocation. Chromosome 13, 14, 15, 21, 22. All these are acrocentric chromosomes. I think this was one of the questions which came in INICET. I was informed that it's chromosome 13 or 14. I'm not exactly sure. If it is 13 or 14, it has to be an acrocentric chromosome, because it was the image and one of the chromosomes was marked. That is a recall which came in INICET. If it is one of them, it has to be an acrocentric chromosome, right? And option B, deletion of both the ends and fusion of the damaged ends. What type of anomaly will option B result in? Option B also results in a very classical anomaly. What type of anomaly is that? I'll draw whatever is mentioned there. Then maybe you'll be able to understand it. Okay, let's say that this is a normal chromosome. The ends are broken. Perfect, right? When the ends are broken, the ends become sticky, and when the ends are broken, they merge together, right? This is called as a ring chromosome. A ring chromosome can cause Turners. The good thing, or how do I identify ring chromosome causing Turners is, what do we generally have in Turner syndrome? The genotype of Turners, it is 46 or 45. Turner's genotype is 45 X0 or X0, right? When it's caused by a ring chromosome, if ring chromosome causes Turners, it will be 46 chromosome X and RX. If it's RX, which means it's ring chromosome. But when it's ring chromosome, it will be mentioned 46 only, not 45. Because this ring chromosome, it's structurally present. Will the ring chromosome function? They won't function, because for me to function, it has to be open, right? So the ring chromosome is structurally present, but function is absent here, fine? That's how it happens, fine? So you have a ring chromosome, it's going to be 46, R in brackets, I'm going to call it a ring chromosome, fine? Division of centromere to fail, division of centromere along the transverse plane. What will this cause? What will this result into? Again, when I say division of centromere, this is how a chromosome will divide normally. When I have a normal chromosome, it will normally divide in the vertical plane. When it's divided into vertical plane, I'll have one short arm, one long arm into one cell, other short arm and other long arm into other cell. Transverse plane means it's going to divide like this, which means I'm going to have both the long arms in one cell and both the short arms in other cell. I'll have this in one cell, this in one cell. We call this isochromosome. Okay, we call this isochromosome. This will result in an isochromosome. Fine, that's what happens. Perfect. Yeah, either with one leaf with longer or one leaf with shorter. Failure of homologous separation of pair chromatids separate. This is my non-disjunction, which causes your classical aneuploidy. Fine. Two breaks within the same segment and reincorporating in the inverse segment. As the name says, it's how inversion presents. The one classical inversion which I want every one of you to know is inversion 16. Which disease will have inversion 16? It's a very classical inversion. There's only inversion which is actually required for me for a clinical practice, at least for undergraduate level. Inversion 16 causes acute myeloid leukemia, right? It causes AML, it causes acute myeloid leukemia. That's one of the classical mutations seen in acute myeloid leukemia. And in inversion 16, we'll have AML with increase in amount of eosinophils. That's also something. Yeah, AML M4, perfect. Well, increased amount of eosinophils. That's also classical for this inversion 16. So you have to know it. Okay. Last two questions. Okay, read the question and give an answer. Okay, the answer for that evidence is option D. This question, perfect, it's option B. What is the diagnosis here? The mewing cry, high-pitched cry, that's classical for your cri-do chat. Cri-do chat is crying like an cat, right? A high-pitched cry. Cri-do chat syndrome. Cri-do chat is 5p deletion. This was asked once in AIMS as an karyotype image. One of the chromosomes was smaller and the other was bigger. That's diagnostic of cri-do chat syndrome, a partial deletion of your short arm of your fifth chromosome. Fine. Okay, next. This is also classical. Answer? I thought you won't require much of time here. Yeah, perfect, right? This is a classical case of Angelman. Angelman, one of the classical finding here is laughter at inappropriate times. And inappropriate laughter, that should give you a diagnosis of a happy puppet, it's Angelman. Prader-Willi will have a classical symptom again, hyperphagia. The patient will be hyperphagic, and because of that, the patient will be obese. The hyperphagia is due to increase in ghrelin secretion. All of them were asked previously, so I should know about the disease. Fine. That's how classically your Prader-Willi will present. Fine. So both of them come under a disease called as an imprinting disorder. Right. I'm sure you must have known about imprinting disorder. I'm sure you must have known about mnemonics to remember your Angelman and Prader-Willi as well. I have a good one. It's not my mnemonic. It's one of my students called Dr. Nishant. It's gene silencing related, right? So thanks to Dr. Nishant, and we'll try to remember that, right? It's a very good one, what he created, and it can be easily reproduced. What he said was, there's a kid called Angel, who was 15 years old, and the kid's mom and dad had a divorce. That's what he started the story with. And the mom and dad had divorce. It's a kid, 15-year-old kid, right? I'll tell you, Vishwa, fine? So the dad went out because the kid, 15-year-old, and the kid was living with mom. And the mom and the kid was very happy. Mom and Angel was very happy. One abnormal day, the mom died, fine? I like this story. Nishant is an amazing person who created this story for all of us to help, fine? When the mom died, Angel went in search of a man, became Angelman, and became a syndrome, right? If you think marriage is happy, the symptom is happy puppets, inappropriate laughter, inappropriate thing. So definitely it's sad, right? So that's what he did for your Angelman syndrome. So I can relate this to the disease per se, right? It's a very, very good story. The chromosome is in 15. And what he compared Angel is, angel or God and demon as per the religion is present ubiquitous. It's seen everywhere, right? So like that, angel, the disease is involving a gene called as ubiquitin 3A gene. The gene is also present everywhere. Ubiquitin 3A. Ubiquitous, right? Something is normal here. When the dad was removed out of the relationship, the mom and Angel didn't have any problem. They are completely fine. In other words, all our dad's chromosome is imprinted or silenced. That is not the disease. Remember that always. That is never the disease, fine? So normally what will happen is the paternal gene will be silenced or imprinted, right? When I have a paternal gene silencing, just tell me I have only one gene functioning for all the normal human beings. Which gene is that? From dad or from mom? There's only one gene functioning here. That's from dad or from the mom? That has to be from the mom. So if that gene gets deleted, that's when the mom dies. So the pathogenesis here is simple. When I'm going to have a maternal deletion, when I have a maternal deletion, that's classical disease for me, Angelman. When the mom's genes get deleted, there's no functioning ubiquitin 3A gene, I'll have an Angelman syndrome. The other way of thing is, if by chance, if a person gets two ubiquitin 3As, both of them from the dad, will my body silence both? It will silence both, right? So those I'm going to call it a disomy. Di is two, somy is chromosomes. If I'm going to get both the chromosomes from the dad, I use the term paternal disomy. When the person has a paternal disomy, which means both the chromosome 15 coming from dad, which means both of them are silenced, then there will be no functional allele. The patient will have Angelman syndrome, right? So this is my pathogenesis. This is completely normal. That is not the disease. For you and for me, for every human being, the dad's allele will be silenced. That's how it is, right? So this is about Angelman syndrome. This was told by one of the students. So if you have any good mnemonics, let me know. I'll tell everyone with your name, right? I'm not going to take a credit, and I'm not that person who's going to take anyone's credit. So if you have any good mnemonics, which is good enough, let me know. I'll tell others, fine? So remember this. Hopefully you'll be able to recollect. If you know this, Prader-Willi is exactly the opposite. The only difference is gene. In Prader-Willi, I will have your maternal silencing, which is normal. Prader-Willi will have your dad's deletion, paternal deletion, and Prader-Willi will have maternal disomy, again mom's disomy, right? Exactly opposite for Prader-Willi. The only change is the gene change, that's all. Chromosome also is the same, fine? Okay, let's go to the last one before we can call it off. Okay, read the question. This is a simple one, but don't make a mistake here. Okay, great. Sayantan has started the thing. It's a classical case of the glomerulus in minutes after the kidney transplant. That's the clue for me. Minutes after the transplant, there's a rejection happening. So there's an hyperacute graft rejections. We all know that hyperacute graft rejection is due to preformed antibodies. The thing is, I can have two very close options, right? The good thing, if you know something completely, you can answer this question. We know superficially, it might be difficult for me to answer the question. It's a preformed host antibody, which means I am having an antibody against the donor already present. So when the donor has a transplant, automatically kill it off and it will reject it off, right? It's a preformed host antibody against the donor, which means it will reject immediately. This has to be stopped. That's why we have a test called as an preformed donor antibody test. When we do that, I can easily prevent the rejection. This has to be prevented at any cost, right? The person who can have this preformed host antibodies, person who had multiple transfusions, they are predisposed to it, or and multiparous women. Doesn't mean that people who are not multiparous and who has not got a transfusion will not have an hyperacute graft rejection. They also can. So donor and specific antibodies has to be done at any cost, fine? Okay, so a few questions regarding your MLE pattern. Hopefully it will help you in future. And if you are getting enrolled in any of the courses, you can use PathoCups if you want a discount, or you can have any code, you can use any of them, fine? Okay, so there are few updates for you. Like what I started with was this. We have two of series going on as special class in the Unacademy app. One is Disease 360. Someone of you asked for a detailed discussion of tiny topics. We'll be doing this. and by Monday, Tuesday and Wednesday we'll do this these 3 topics, and this will be MCQ discussions. Right, Vishwa, if you want MCQ discussion of this sort, you can come to the Unacademy app, you can use PathoCups and you can enroll to that, and all of them, these 2 sessions will be free. From 8 to 9 will be the MCQ discussion, and from 9 to 10 we'll be having a theory discussion. Fine. Thank you for your time. See you soon in one other thing, and hopefully we'll read more. Sure, happy doctor, we'll do for USMLE. Fine. Thank you. Bye-bye.